All right, good evening. How's everyone doing tonight? All right. I'm going to talk to the folks that aren't getting food right now, but we're going to go ahead and get started. I hope that everyone is enjoying day one of this year's annual summit on health disparities. We're going to get started. We're going to get you fed, and most important, we're going to have a productive conversation on reimagining our healthcare to protect the most vulnerable. My name is Brandon Webb. I'm a former executive director of the Congressional Black Caucus Health Braintrust. Thank you. And I am here for three reasons in order. One, because Dr. Congresswoman Robin Kelly told me to be here. And when Robin Kelly says show up, you show up. Number two, there's still so much that we need to do to close the equity gaps that exist. So that's my second reason for being here, but really it's number one. And number three, some of the folks in the room know this, but not everyone. Once a year, for 2 nights only, for the past 9 years, the Brandons, Brandon Webb and Brandon Garrett, come together and continue this show. So this is year 9 of the Brandons doing the NMQF Health Equity Summit. And if you don't know a Brandon, I recommend you introduce yourself to one. It's the official name of the 1980s, but we have 2 great Brandons here. At least one great Brandon here, Brandon Garrett, with the National Minority Equality Forum. I want to thank everyone for being part of this critical conversation, which focuses on the conference theme, Reimagining Our Healthcare to Protect the Most Vulnerable. Tonight's panel will discuss key stakeholders in industry and what they can do to improve and protect the most vulnerable as we reimagine the future of health. So as we get started, I am joined by 6 brilliant minds at the forefront of the health equity crusade. In alphabetical order, I should acknowledge our panelists, and I'm going to read the bios. I will read because I don't want to offend the degreed. So I'm going to read the bios in their entirety. But first, we have Dr. Van Coots, President and CEO, Holy Cross Health, Maryland Regional Trinity Health. Retired Brigadier General Van Coots is the former Commanding General and CEO of Regional Health Command Europe and Command Surgeon, U.S. Army Europe and 7th Army. He has more than 20 years experience in all aspects of healthcare management and medical administration. Previously, Dr. Coots served as the Deputy Commanding General for the Army Medical Command and as Assistant Surgeon General for Force Projection at the Pentagon and as Surgeon General, United States Forces, Afghanistan. We had a back and forth battle. There wasn't a winner. Dr. Coots attended Howard University. I'm a Hampton man. He's doing all right. Your bio's a lot longer than mine, so Howard did something right there. And subsequently, he earned his undergraduate degree from the University of the State of New York, Regents College. He has a Master's of Strategic Studies from the U.S. Army War College in Carlisle, Pennsylvania, and his Doctor of Medicine from the University of Oklahoma Health Science Center College of Medicine in Oklahoma City, Oklahoma. Welcome, Dr. Coots. Next, we have Dr. Greg Daniel, Vice President and Head of Global Public Policy, Eli Lilly and Company. Dr. Daniel is an executive leader in health policy, pharmaceutical, and medical device policy. He is dedicated to advancing policies that encourage and support high-value breakthrough innovation that meets patient unmet needs and at the same time enables equal and affordable access to such treatments. Before entering his current role as Global Head of Public Policy at Eli Lilly, Dr. Daniel was previously the Editor-in-Chief for Therapeutic Innovation and Regulatory Science, a peer-reviewed scientific journal, as well as President for the Board of Directors of Innovation and Value Initiative. Dr. Daniel received a Bachelor of Science in Pharmacy, a Master of Science in Pharmaceutical Science, and a Master of Public Health Biostatistics, all from Ohio State University. He then, there we go. I should have said the Ohio State University. He received his doctorate of philosophy, pharmaceutical economics, policy, and outcomes from the University of Arizona. No Arizonans? You destroyed my March Madness bracket with Ohio State and Arizona. Welcome. Following him, we have John Mathewson, COO of America's Health Insurance Plans. AHIP is a national association whose members provide healthcare coverage and related services to hundreds of millions of Americans. In this role, John serves as the overall enterprise leader of AHIP's business operations and spearheads the organization's strategic planning, as well as its strategic focus on diversity, health, equity, and inclusion. Kind of the reasons that we're here, right? Before joining AHIP in 2018, John served as interim president and CEO for the DC Primary Care Association. Prior to that, he was executive vice president for strategy and operations for the HSC Foundation and Healthcare System, an integrated health system and health plan for young people with disabilities. John's career also included leadership roles at Cigna and Kaiser Permanente, as well as chief marketing officer roles for other health plans. John earned a master's in health services administration from the George Washington University and a Bachelor of Science degree in chemistry from the other HU, Howard University. I'll just get it out of the way. If you went to Howard, say it now. There you go. Welcome. Next, I have my guy, my fraternity brother, Dr. Gary Puckrin, President and CEO of the National Minority Quality Forum, a not-for-profit organization that he founded in 1998. The NMQF has received support from a wide variety of organizations, including federal agencies, pharmaceutical companies, payers, and trade associations, with support from the U.S. Department of Health and Human Services and the Robert Wood Johnson Foundation. The forum undertook the zip code analysis project, developing a comprehensive database that links vital statistics and other elements, including demographic, environmental, claims, prescription, laboratory, hospital, and clinic data in a centralized data warehouse organized around zip codes. Dr. Puckrin is a Phi Beta Kappa graduate of Brown University, where he received his master's degree and doctorate. Between 1974 and 1992, he taught and lectured at Roger Williams College, Brown University, Connecticut College, and Rutgers University, where he was a tenured member of the faculty. Dr. Puckrin, thank you for having us. Next is Dr. Willie Underwood III, Board of Trustees at the American Medical Association. Dr. Underwood is a board-certified urologist with more than 20 years of overall urologic surgery experience, including more than 10 years focused on robotic urologic surgery. He was elected to the American Medical Association Board of Trustees in June 2019. There we go. An expert in healthcare disparities and healthcare policy, Dr. Underwood has served on several national and regional healthcare policy committees, including as a board member of the Highmark Blue Cross Blue Shield of Western and Northeastern New York and the Board of Commissioners of the Joint Commission. Dr. Underwood earned his Bachelor of Science degree in biology from Morehouse College. There we go. It's HBCU night up here. And his Doctor of Medicine and Master of Science in Anatomy and Cellular Biology degrees from the State University of New York, Upstate Medical University, Syracuse, New York. He received his general surgery. This is going to be a fun night. He received his general surgery and urologic surgery training at the University of Connecticut Healthcare Center. And so welcome, Dr. Underwood. And only because alphabetical order trumped my chivalry for the evening, my first becomes the last. And I want to introduce Dr. Britt Weinstock, Senior Advisor of the Health Equity Strategies Group, LLC, former Staff Director, Senate Health Committee, and Primary Health Director of Health Policy with the United States House of Representatives. Britt has worked in the fields of health equity, health policy, public health planning, assessment and evaluation, and health financing for more than 2 decades, and has received numerous awards for national organizations recognizing and applauding her work in these fields. Dr. Weinstock currently serves as the Chief Principal and Strategist at the Health Equity Strategies Group. In this capacity, she brings nearly 25 years of substantive and diverse experiences in the health arena. Dr. Weinstock received her PhD in medical sociology and social inequity with a minor in bioethics, a Master's of Arts degree from Georgetown University, and a Bachelor of Arts degree from Bucknell University. So, Dr. Weinstock, thank you for joining us. All right, so I'm going to just dive into the questions, and I want to return to our dinner. I want to return our dinner attendees to the theme of this panel: reimagining our healthcare to protect the most vulnerable. So in that vein, my first question is the following, and we can go in any order, but what do you think you and your industry can improve in the health space, and what is being done right to protect the most vulnerable as we reimagine the future of health? So I will start coming in.
Okay, thank you very much. Is my mic on? Can you hear me? Okay. No, it was, there we go.
There we go.
So, protecting the most vulnerable. So I can't speak for all health systems, although I'm sort of speaking for the health industry, but I can certainly say that that is what hospitals do on a daily basis, and particularly those safety net hospitals do that every second of every day. So I am part of Trinity Health, which is the third largest Catholic health system in the United States, definitely safety net. And so we save countless lives every day. We, aside from diagnosing and treating and caring for people, but we really try to ensure that they live their best health. So during COVID-19, not only did we treat, but we researched, and then we actually flexed and filled in the gap where we found that the public health system was broken or was not responding. And we actually had to step in and take over that, from prevention to pop-up vaccine clinics to doing zip code level threat assessments, and really by quickly flexing to just about anything and everything that we could do by telehealth and telemedicine. We made major investments in health equity, particularly trying to get upstream by assessing all of the social needs, so specifically in the areas of food insecurity, both inside of our hospitals and health systems as well as in the general community, and then in housing security. And for many hospital systems, they also realized that they also had to get involved in transportation security as well. And as one of my friends in the Indian Health Service said, really, it's not just that, but ultimately where you have to get is upstream of the social determinants and get to the stress cortisol. And only then will you eliminate health disparities in the United States. And last, I think one of the best things that we've been doing is, once we recognized that there was a workforce crisis in healthcare, we started working on workforce development. But even before that, we had been working in the communities trying to uplift the people that we support, particularly those that are dispossessed, those who are on Medicaid and need something stable, by creating workforce development programs. And that's through partnering with community level partners, with the state, with the county, and even the federal government for different levels of funding, some of it funded by the hospitals themselves. But ultimately, the goal is to uplift as many people as we can, to give them an opportunity to make a living and have a decent life as well.
Thank you. Dr. Daniel?
Sure. First, let me just say that if you look at your agenda, I'm not actually supposed to be on this panel. Unfortunately, Kelly Copes-Anderson, who's the Vice President of Diversity, Equity, and Inclusion at Eli Lilly, unfortunately could not make it. She had a death in her family. We found out just a couple of days ago, and I was able to participate. So if you don't mind, I'm going to use my notes more than I normally would have in preparing for this. I'd also just like to thank Brandon for moderating, and NMQF, and Gary for all of your partnership with Eli Lilly, your leadership in this space, and convening this event. So when I think about Lilly as a large global biopharmaceutical company, we're investing in many areas, including neurological diseases like Alzheimer's disease, diabetes and obesity, immunology, cancer, and we even make a COVID therapeutic, monoclonal antibody. There are three things that I'm really excited about. I've just been with Lilly for 2 years. There are three things that are going on today at Lilly that I'm very excited about as it relates to improving care for the underserved. The first thing is that you may not know this, Eli Lilly is headquartered in Indianapolis. In Indianapolis, there are zip codes. And believe it or not, there are meaningful differences from zip code to zip code around Indianapolis as it relates to life expectancy. Also, the prevalence of diabetes and obesity around the Indianapolis metropolitan area is staggering. So Eli Lilly partnered with Purdue University and Indiana University and Eskenazi Health to launch a program, a 5-year program, $7 million investment called DIP IN, which stands for the Diabetes Impact Project Indianapolis Neighborhoods. And essentially, the goal there was to connect with the underserved population in and around Indianapolis and help to bring and connect those populations with high-quality care in diabetes. The long-term goal was to reduce diabetes-related complications and ultimately reduce the rate of diabetes, but also to improve quality of life, to increase awareness of risk factors, to connect those individuals with healthcare, and to spur community leaders to help connect those. So the community leaders are community health workers. This program was launched during COVID, and despite that time, we saw meaningful improvement in hemoglobin A1C. But we learned something as well at Lilly, and we learned that community health workers can bring a significant amount of value to the underserved population and healthcare systems as a whole. We decided to launch the Community Health Worker Policy Forum, which is a direct result of our dip-in experience, but we decided to say, well, let's not just focus in Indiana. Let's not just focus in the areas that Lilly is investing in. Let's figure out how we can support and improve the ability for community health workers to bring high-quality care. And we realized that there are a number of barriers, despite the value that community health workers can bring. There are a number of barriers that they experience in terms of having funding, being reimbursed for the services that they provide. We started to learn exactly what community health workers do. They spend a lot of time with the underserved population, just engaging in conversation, building trust, understanding disparities that they have, understanding social determinants of health. And believe it or not, the reimbursement mechanism is 30-minute conversation. That's when you stop because of the reimbursement. So we joined forces with the Indiana Community Health Workers Association, Purdue, Indiana University Fairbanks School of Public Health, Diabetes Youth Foundation in Indiana, Eskenazi Health, the National Health Council, maybe they're here today, they're here in Washington, D.C., the National Hispanic Caucus of State Legislatures, the National Black Caucus of State Legislatures, to come around. And Lilly, we realized, we know the least about community health workers. So we brought all of these organizations who are thinking about what are the best policy solutions for community health workers. We're convening them. We're creating a national agenda. They're educating us, but we're also bringing some resources to develop that national agenda so that we can have more funding, more reimbursement for community health workers. That was number two. The third thing, on March 1st, I mentioned that Eli Lilly invests in diabetes. We make a number of insulin products as well. On March 1st, we announced significant price reductions in our insulins, Humulin and Humalog, which are two of the most commonly prescribed insulins. We reduced the price by 70%. We also make a non-branded generic that we're bringing to market with $25 a vial. We also are launching a program that brings the out-of-pocket cost for a patient with diabetes. If you're on a Lilly insulin product, you will not pay more than $35 a month, regardless of what your insurance status is. You might have insurance and your copay for that insurance might be higher than $35. We buy that down. So anybody on a Lilly insulin will only pay $35 a month. That's in the commercial sector. Medicare, as we know, the Inflation Reduction Act already brought the CMMI model, which was the senior savings model that had already reduced patient out-of-pocket costs if you're in the Medicare program to $35. The Inflation Reduction Act codified that and made it law, but nothing was there for the commercial community except for voluntary programs that pharmaceutical manufacturers have. So now, because of this program, regardless of if you have insurance, if you don't have insurance, or if you're in Medicare, all Lilly insulins are $35 a month. So one of the questions, thank you. One of the questions was, what can we do better? We are investing, as I mentioned, in obesity as well. That is an area, and I'm just new to Lilly, I'm learning about this, but the obesity issue within the United States is significant. 50% of Black adults have obesity, 45% of Hispanic adults have obesity. On average in the United States, only 3% of patients with obesity are actually treated with anti-obesity medications, which today there's one on the market that's from another pharmaceutical company, significant reductions in weight. But because the Medicare program doesn't cover anti-obesity medications and there are a lot of other challenges that patients have in the healthcare system, many patients don't have access to those treatments. Many patients don't have access to high-quality obesity care. That's an area where we can do better. And I know we talk about reimagining healthcare. We can get back to the basics and do those better too. Diabetes, 50% of patients with diabetes are not reaching their hemoglobin A1C levels. Patients with obesity don't have access to treatment. These are things that when I think about reimagining healthcare, That's what we need to think about in terms of across all diseases, not just the ones I've mentioned. Are we getting the right diagnosis, screening, treatment? Are patients getting treated? Are they able to get better health outcomes on health outcomes that they prioritize? And I think that's where we can think about starting.
Thank you. John?
Good evening, everybody. How are you? So good that that dinner rush hasn't quite taken you down just yet. Just checking to make sure. I am grateful and thankful to be here, and just want to applaud the National Minority Equality Forum for having this vector, having this voice. That's very important, and you'll probably hear just kind of dotted among my comments later on in the meeting that having that voice and this vector is very important. And I'm going to speak to you probably a little bit differently. I'm certainly here representing the Health Insurance Trade Association, or GAR. But I always have a point of view, and my point of view comes from my own lived life experience. And so I grew up in a small town in eastern North Carolina. My father dies from smoking when he's only 51, Camel, unfiltered. I'm 4.5. I never forgot. I'm still here now as a grown man, and I'm talking to you about it. So when I'm saying what we're talking about in terms of reimagining the future, that's been with me all of my life. And so we're going to be on this journey together. You're here because of that same commitment, and whatever story you have, and you all have stories, I'm sure you do, but that is the driver that has you where you are. So let me talk a little bit about where the industry is. Again, I'll give comments throughout. And there's one last little piece in here that just underscores why this is so personal to me and why I have a vested interest in seeing that this works. I'm an 18-year prostate cancer survivor. Thank you. Thank you. It's good to be here. We have a 17-year-old daughter, and we call her our miracle child, my favorite daughter. So there you go. AHIP represents, of course, the health insurance industry. We have about 130 members. They touch more than 200 million through various products, all 50 states. When I'm talking with friends and they want to know what I do, I said, think of it as the NFL. And so for a trade association for health insurance, that's really what it is. You see this extraordinary landscape that is quite vast and unusual. And I'll tell them, if you see something on the news about healthcare, there's chances are that someone in our office has touched it, was working on it somehow or another. And so it's a very rare room, one that I respect a great deal because of the important things that are being discussed. And I can also share that not only the important things being discussed, there are people in there who really care, who have a deep sense of responsibility about what it is we're trying to do. So as it relates to equity, certainly this has been a long journey. This didn't start, 2 years ago or 5 years ago, although we all know the George Floyd incident was an inflection point combined with what happened with COVID. I think it was very freeing from my experience in corporate America. The discussions we could have, to me, were very candid, very blunt, and more honest than I ever remember having anywhere before. And it made me feel good. Often enough, I'm the only in the room, but that's changing. That's changing a lot. It needs to change more. But it doesn't matter about what your cultural background is. It just matters about do you care and what do you do. And from the plan perspective, they were on it right away and just have it. Some of our plans grew up around community health centers, have been doing this for decades, deeply immersed into communities where equity and looking at what the community needs are very important and very robust. And so in some ways, this conversation wasn't new to them. It was just the permission for everyone else to begin to talk about what their commitment had been for you. And then others were able to amplify it in another way. So certainly the word of the century in some ways is social determinants of health. I can tell you, you can't go to a healthcare conference where that's not being talked about, even if that's not the topic of the conversation or whatever presentation at the time. They're all deeply immersed in that in different ways, whether it's food insecurity, housing, different things as you're looking at how do you affect the population, what's important, how can you go about it, how can you. And so that's a kind of a broad brush overview of just here's the things that they're looking at, what they're working on right now. And of course, we all know, well, otherwise we wouldn't be here. If everything was working right, we wouldn't be in this room, right? If everything was going just fine, it would be an easy fix and it's done. But we all know that it's very difficult, it's very hard, and this is definitely a marathon race as we think about the Boston Marathon. And that marathon race is going to have lots of elements. First and foremost, what I think about trust. You could have the rich coverage in the world. You could have the best therapeutics in the world. You could have the greatest liver system in the world. It doesn't matter if there isn't some level of fundamental trust, and we certainly saw that with COVID. And so that's one of the things that we all have to work on, and that's an ecosystem piece. It's not just on the health plans or the health insurers. That's together, and it's not only trust that goes out and with patients or covered lives. It's among each other as well. All of those things become very, very central. What we did discover in another way, although we knew that it was there, health insurers in many ways are very specialized information, hyper specialized information. And during COVID, what we realized, and the ecosystem realized it too, that we didn't have good data that was as useful to us as we needed. So there's a lot of energy going in on where do we get the data? How's that data normalized so that it's usable across all the different entities in the ecosystem? And that's very important. The next place that there's this continuous opportunities for improvement is really what happens with the workforce. And that's going to be very important as you look at diversity of networks. And in some ways, there's some real challenges. I think there was just a stat article that came out within the past week, and it talked about how Black communities, when there was a Black doctor, their longevity, their life longevity goes up, it increases. That's wonderful, it's great. Only problem is there are only 40 to 45,000 Black physicians, and they don't all practice. So you're gonna have to find another vector somehow or another for someone who cares about you. The moment of truth is when you need that care. Again, the coverage can be great. Your moment of truth is, are you looking at me? Are you taking care of me and paying attention to what I need? So that's just one of the many things that can be added to the truck, if you will. What can we improve? What can we do? Where can we focus? What I'm encouraged about is the attention is there. The conversations are there. Conversations are no longer hidden. It's no longer off to the side. They're very dedicated, very focused conversations about it. But the fixes are going to be difficult. And that's why it's important to have this particular channel and many others, thousands of others, that are a voice and a vector for expressing how you feel, what you see.
Thank you. Dr. Parker?
So anyone who knows me knows that the historian in me has to start you with the past. I want to talk a little bit about the present and then a little bit more about the future. American history, it was once okay to have inequalities in this, both by practice and by law. Our hospitals were segregated, our medical societies were segregated, and even as late as 65, if you went into many African American communities, there weren't any healthcare facilities really to take care of people. It was actually government health insurance, Medicare and Medicaid, that began to bring down those barriers. But the legacy systems still discriminate, deeply discriminate. It is important for us, one, to say that out loud, that the system is discriminating and not providing quality care to everyone that comes through the front door. The present reality is that we have an emerging new market in American healthcare. If you look at the demographics, the majority of people under the age of 18 are minority. By the time we get to 2030, for all intents and purposes, the majority population is going to be diverse. Historically, we did not provide quality care to diverse populations by practice. In fact, if you take a deep dive, there's some posters out there that we put up with a Q code. One of them is on rationing. If you look at the literature, the historical literature, it talks about how the American healthcare was rationing back in the 80s and 90s when the system was being set up. This new market is also has a political voice to it. Members like Robin Kelly and Barbara Lee and others are looking at the healthcare system from the lens of their constituency, and their constituencies are pushing them for equity in healthcare. It's not accidental that we're having this conversation. It's being driven by the changing demographic. So that is the hard reality. When we start to think about health equity, again, I'm an academic, and what I realize is that if we're really going to do health equity, we have to have an intellectual framework for it. It has to be rooted in the science. The care that we're talking about is delivering high quality care to communities driven by the science, but we don't have all the science that we need for minority communities, because not only did we not put healthcare systems in their community, we didn't collect the data. And let me give you two quick numbers to bear in mind, a couple of quick numbers to bear in mind. 38,000 zip codes in the United States where people live. 70% of African Americans live in 2,500 zip codes. 70% of Hispanics are in 2,500 zip codes. 50% of Asians are in 1,500 zip codes. So roughly 8,000 zip codes around the country, and the Native American population is also geographically. We didn't collect a lot of data. We started it, and what we were finding out is, yes, the higher death rates are in those zip codes. That's where the disparities are. And so when we started to look at this question, the first question we had to ask ourselves is, what is the purpose of healthcare? What is it supposed to be doing, right? I mean, think about it for a second. What is healthcare really about? And when we looked at it and thought about it internally, what we realized is that the purpose of healthcare is to mitigate patient risk. You want to keep them out of the hospital. You want to keep them out of the emergency room. You want to keep them from disability. You want to keep them from dying, and you want them to have a high quality life. That is the single purpose of healthcare. Mitigate patient risk. If you're not doing that, then you're really not doing healthcare. And so when we think about that, we think about how do we apply all of that to these communities that historically have been left out. And we think that those are the methodological principles of the health equity movement, that it has to have an intellectual foundation. And so we think about that as the intellectual foundation on which we get started in the conversation about how do we do health equity. And also to ask all of the providers and everybody who's in the healthcare system to look internally and try to understand, is that really what healthcare is about? And if it is, are we living up to that code? Are we really trying to do that for every individual that comes through the front door, no matter who they are? Right? So that's the question, what the reimagining is about. And if you come up with a different set of principles, because I'm an academic, I love the argument. And so if you think there's another way that we ought to conceive of healthcare, we're willing to have that argument. But we think that when we break it down to its fundamentals, that is what we're trying to do. That's why doctors become doctors. That's why nurses become nurses. That's why pharmacists become pharmacists. And that's why us patient advocates become patient advocates. So we're all aligned. We want to make sure that everybody comes in the front door to get health. So that's the present. That's what we're at. But there's something deeper going on here. What's going on deeper is that we are getting very, very smart. We are now editing our own DNA. It's like we took over the computer, right? The DNA is the software of us. And we've taken it over, and we're starting to use that knowledge to control health outcomes, right? And so really, if you think aspirationally, where are we going? We're going to control our own body. That's the purpose. At the end of the day, right? But by the time we get to 2050, we don't want to deal with cancer anymore. We don't want to deal with diabetes. We don't want to deal with cardiovascular. We want to move on to other bigger and better things. And we have the power to do that any moment of the day. Any moment of the day, we wake up and collectively say, this is our purpose, here's our goal. We're going to be very intentional about it. We're going to be very structured about it, because the people who, at least in the African American community, whose backs we stand on, that's what they would want us to tell you. That is what they worked generations so that we can sit on this stage and deliver that message to you, that you have a purpose that you have to fulfill. And I think that is the purpose of the American dream. That is our social contract. If you go back to Jefferson in that first version of the Declaration of Independence, it didn't say life, liberty, and the pursuit of happiness. It said the preservation of life. That's why we have the social contract, because it's a collaboration, a community that comes together. We left the state of nature so that we could work together. I think that's what the reimagining is about. I'm thinking that we got to give ourselves permission to stand outside of the system that we're in right now and think about, how do we use all that AI stuff? How do we use that genomic data? How do we use all these devices for a single purpose? And that purpose is to control our own body and make sure. So I laugh with staff, because I tell them a tortoise lives to be 190 years old. I don't know who's smarter, the tortoise or us, but they get to live 190 years. So we're chasing the tortoise. That's what we're doing. We're trying to catch up to the tortoise. That is a whole paradigm about whether you can catch the tortoise or not, but I'm not going to get into that right now. But the point I'm trying to make to you is, we have to give ourselves the freedom to reimagine a healthcare system that really serves our community. Think about it. All of the COVID, if COVID didn't teach us anything, it's like, we have to control that. We can't have a pandemic running amok in our communities, killing off millions of Americans because we decide that we don't want to do something about it. That's outrageous, right? So I'm excited because there are really very, very smart people in the room. I look at Dr. Valencia over there, and you got to know her. She is incredible in the work that she's doing and the students that she's teaching. Incredible. You look at our 40 under 40s, they're so damn smart. I don't even know how to get that smart so early, right? I mean, how do they do that, right? But that's the generation that's going to take over, right? And so when I talk and think about the reimagining, is certainly what we think about at NMQF, we're thinking about a future that's very, very different than the 20th century and the 19th century and the 18th century. We're talking about a new America that's really driving healthcare to a purpose.
Fantastic. I want to allow Dr. Underwood and Dr. Weinstock to get in there.
Oh man, I'm ready to go. Come on. Hey. So I'm going to answer the question in two ways. So let's first, Willie Underwood on the board, went to Michigan, by the way, the University of Michigan, for my master's in public health. I just had to get that out. That was whole time. No, but so let's think about AMA, right? So the American Medical Association, 176 years, right? 2 African-American presidents, 3, if I win the election in June, 3 would have been chair of the board. I'll be the 3rd. Reimagining future is that's something that we never ever talk about. You know what I'm saying? That who's in what position and who's making what contributions is expected. It's normative. Yes, of course. Why not? That's the way it is. Okay, right? But right now, that's not the case. So first, we got to reimagine how we train, recruit, develop physicians. So we have reimagining the future of medicine and medical education, number 1. Number 2, we have to educate the workforce to how we got to where we are. Because if you don't do that, if you don't understand history, and I tell this to my upper middle class, my rich black friend. I say, look, you know, you got to teach them, you got to teach your kids history. But why do I want to tell them that? Why do I want to show them that? Why should they be watching 12 Years a Slave, reading a book, talking about it? I said, this is why. And this is normal. This is normal for human beings. Your mind has to put the world in a perspective, right? It has to make sense to you, right? So if I don't tell you how we got to where we are, then the automatically assumption is this. All the white people are smart, worked hard, built America, and all the black people are young, stupid, and poor, and they deserve to be poor. It's the comment you look at it, right? So when their kids grow up and they haven't had these conversations with them and taught them, then they go to school and say, I don't know what's wrong with you. My mom and daddy are doctor. What's wrong with you? Because they don't know what's going on in that school, in that community, and everything, right? So we become judgmental. But once you know history and you're able to see the role that everyone played in it, now you can take accountability to correcting it. So our Center for Health Equity, right, when they came out with their report, said, yes, this is the role we played, and here's our future of correcting it. Period. Let's move forward, right? Truth and reconciliation, right? Trust. We're moving that forward. We got the co-chair here. Where's? Right there. Neva, stand up quickly. So where'd she go? There she is, right? Right. Moving that forward. Retrain physicians, get a different workforce. Let's talk about our past. Let's resolve this. Let's sort of make this happen. That's the task force. Health 2047. That's our incubator, right? Innovation Center. So how do we reimagine the future? We think about it the way physicians should be thinking about technology and healthcare delivery that makes it better for all of us, right? Period, right? We have to be able to do that, and that's what we're doing. I got the list here. I don't want to miss anything and get in trouble. Mm-hmm. All right, so racism. So the AMA said racism is a threat to public health. Whoa. Let's change the conversation. I don't care what you think about it. It's a threat to public health. Threat to public health means that it's a threat to the public, the health of the public, all of us, right? Now, when you start to have these conversations, that's when Deloitte, right, starting with Levish's work that was published in Health Affairs 2014, 12, okay, right? So then you have this. So Deloitte came out with a study, 2022. The cost of health inequities to the healthcare system, $320 billion. By 2040, it will be $1 trillion or more. This is what I know about American history. We're a capitalistic society, right? We believe in making money. So I don't care what we think. If we don't figure out, think about it. What does it mean in 2040 that $1 trillion is added to the health system just because you can't figure out how to treat people with brown skin, blacks, Hispanics, Native Americans, right, appropriately to improve their health outcomes and eliminate the gap of 12 and 14 years of life expectancy. That's what we're doing. That's what we're talking about on the board. That's what we're trying to move forward in HOD, the House of Medicine, for the AMA. That's what we're doing when we start talking about bringing the collective of medical organizations together. Why? We have no other choice. And it's the right thing to do for our nation.
Thank you. Dr. Weinstock.
Thank you. There's a lot. I agree with everything that everybody's. I will just say this. I think that folks talk about the social determinants of health. That's a very popular term people throw around. But I think it's vitally important to remember where those came from. And they come from the political determinants of health that happened hundreds and hundreds of years ago. So as we look to address the current situation where we all are, where it's housing insecurity, food insecurity, why you've got industry being able to build up and create the cancer corridor in the South where rates are through the roof. You know, those all start from laws and policies that were put into place hundreds of years ago. So I think that one of the things that's very important for us to remember is that there's an opportunity to fix those wrongs as well. And I think that fixing those wrongs and undoing them, quite frankly, will help us then address social determinants of health that we're all trying to struggle with today. That's the first thing. I think that the conversation about systemic racism, you know, it's a hard thing to hear as a woman of color, only because I've known it, I felt it. I am the daughter of a white Jewish father and a black mother. So I have seen the healthcare system treat them differently, and they are both providers. So I've grown up with that for my 50 years. So for this moment of reckoning, people recognizing it is very valid and validating. But, you know, what we need to do if we're going to reimagine is do a lot more than just talking about it and getting on Instagram and saying, I'm woke. You know, we need to start, we need to start thinking about how do we leverage our influences in every single solitary position that you hold. You know, I don't care if you're in a nonprofit, if you are on the Hill, if you are a CEO, if you're at a drug company, think about policies that were put into place long before you got there that could be fixed, that could be, you know, tweaked, that could then open the door for equity to come through in a much more profound way. You know, and I appreciate what you're saying about righting wrongs. It was on this stage with Dr. Puckrin years ago that he convened the NMA and the AMA, and there was an apology. And I will never forget that because I was there, and it was really meaningful and it was very moving. And those kinds of moments, and those kinds of, you know, moments of recognition of past wrongs are so vitally important. But, you know, with all due respect, let's think about everything else been in place that hasn't been changed yet. Change things. And so when I think about reimagining the system, I really think about really overhauling it and really making some people uncomfortable and making laws and like programs and policies that are just sort of like assumed to be normal challenge, you know, and I think that that's how we're going to really affect it.
Great.
Britt, if I can punt back to you.
No, geez.
You open it up. You worked for Congress for years for the legendary Dr. Donna Christensen. I don't know if she's still here, but because I'm a former Hill guy, what are some important pieces of legislation in reimagining healthcare and protecting the most vulnerable?
Yeah. So I mean, well, there's obviously the obvious one is the Tri-Caucus Health Disparities bill, right? And that's a bill that's been around. Sorry?
Is that the HIA bill?
Yeah, but it started off, it's now called the Health Equity and Accountability. Yeah. It started off under the late, great Mr. Cummings, was Healthcare Equality Accountability. And it rose out of the IOM report. I think everyone has read that. And what was frustrating was you had literally every Black and brown member of Congress sign on to that piece of legislation. Yet the folks who could move it didn't. And it wasn't until President Obama got into the White House. And even then, it was just portions of that legislation that we're getting. Now, the important thing to also remember is that that bill is very, very aggressive, and it really would fix so much. But it was authorized, and there was never a really good appropriation strategy. So it doesn't really matter if you put into law a program. If you don't have the money behind it, then it's not going to go anywhere. And we saw that happen when the Center for Minority Health and Health Disparities at NIH elevated to an institute under Dr. Ruffin. It was elevated, but he was never given the money to fully hire. You know, I mean, I can go down the list, so many other programs like that. So in terms of, you know, we're thinking about, you know, from the legislative kind of perspective, it's great to authorize, but we need to appropriate, and we need to push for appropriation. When you have health empowerment zones, authorized, never appropriated. I mean, I can literally go down the list. And so I think that that's one of the key things. The other thing I think is also important to mention is that, you know, health equity has become this term, and the number of subpopulations who are now sort of being folded into that population has increased. So essentially, unless you are a wealthy, white, heterosexual man, you fall under that population in some way, shape, or form, which is fine. But then you have a lot of infighting because there's not a lot of money. And so I don't have a solution to how to fix that, but I can say that I have seen countless times, you know, groups that are affected by inequity or disparity fighting. I mean, I'm talking like hardcore fighting, because the money just isn't there, you know. So it really isn't just about just putting it in the books. It's about writing a check behind it.
Thank you. Dr. Underwood, what is the role of the AMA in reimagining, creating, and sustaining such a reimagined healthcare system that supports our most vulnerable patients?
Well, I thought you were going to ask me about legislation. I was looking up.
And add the legislation to that as well.
So I think the role of AMA is twofold. One is a convener, right? We have to bring thought leaders together. And two is also to be a part of the think tank and utilize our resources effectively and wisely. So for example, on the west side of Chicago, West Side United, the AMA working with health systems, multiple health systems, and insurers as well. And on the west side of Chicago, which for me, it's great because that's where my grandfather lived. He ran a gambling joint on the west side of Chicago, and he's the one that told me that I is to improve that and the health outcomes of Black, period. That's why you're going to be a doctor. So, but they're $3 million investment, not a lot of money. But when people come together, they put a plan together. I think they're now up over 100 million. I don't want to misquote 150 million. But this is a development program for the west side of Chicago, which includes economic development, housing, business, those kind of things that will transform jobs, right? Will transform people's health, right? That's not physicians delivering care. That's what are the key components of someone's health outcome and how to fix it, right? Now with the, and I'll make sure I get the act right, the Inflation Reduction Act, which is, $370 billion, right? So in that piece is multiple things, right? But it's housing in there, right? It's housing, and when you start thinking about what type of housing, we now have an opportunity with the right thought to build low income and middle income housing differently than it was done years ago, right? There is no reason that you live. So they're housing in Buffalo, where literally there are holes in the floors and rats coming up through the floors, right? And they're charging $1,200 a month in rent. And you're like, wait a minute, hold up. How can they do that? Because there's a whole lot of people doing it. Now, what happens if someone comes in and builds 2,000, 3,000, 5,000 new units that are nice units with granite countertops, with hardwood floors, right? Guess what? That's on solar, right? Energy efficient so that the electricity bills are down. All those things are better. Those folks with rat-infested houses, they now have to change or they can't make money. Because remember, America is a capitalistic society, right? And I can prove it. So I have property in Gary, Indiana, where I grew up. Okay, right? So I own a block, but it's not a lot of houses, but I own the block. So I decided that I was going to transform those homes so that when people drove by, they would say, wow, who lives there? Okay, right? Hardwood floors, granite countertops. My mother taught me you're gonna rent some house to someone, make it a house that you want to live in, right? If you wouldn't live there, you shouldn't have anyone else living there. Okay, remodel it, right? So, and other investors, they said, well, how do you make money? They said, well, do you have trouble with tenants? Those places are never vacant. because the management, people come by because they heard about how nice they are, right? I was remodeling a house. It was rented 3 months before we were done with the remodeling job. That's what this act can make if we think about it, right? So what I'm trying to say, there's legislation out there. Let's think about it differently, utilize it to improve the community, which in turn, we can improve health outcomes.
Yeah, thank you. And I'm going to swing across the panel, but before I do, I want an honest show of hands because I want to allow for audience questions as well. And you don't look like a shy audience, but you may be a shy audience. Are there folks in the audience that want to ask questions of our panelists? Okay. All the way in the back, I see you. Okay. Anyone? All right. So I'm going to ask one more, and then we're going to get to the folks in the back. And really quick, Dr. Coote, I'm going to get to you. As a former senior military leader, what do you look forward to in the healthcare in the healthcare of veterans?
Yeah, thank you very much. So I think it's the same thing. It's elimination of health disparities. You know, we've got about 18 million veterans in the United States. Only 9 million are eligible for care in the VA in some form or shape or another. The other 9 million get their care either through the public sector and have health insurance or no insurance whatsoever. 40 veterans commit suicide every day. Of the veterans that are out there, about 2 million are female and 2 million are African American. So, you know, we're underrepresented even in an underrepresented population. There are studies that have been done. The RAND Corporation did a couple of studies in the 1990s, in the early 2000s, that said civilian healthcare providers know nothing about the military culture. And so when we talk about to treat me, you have to see me and you have to know me, they're saying that there's a big population of us out there that know nothing about the people in the military and understand their culture. So we have to eliminate those health disparities as well. We've got something now called the PACT Act, which allows for many more people who are veterans, not under VA status, but who may have been exposed to Agent Orange in Vietnam or burn pits in Iraq and Afghanistan and things like that, to now seek care. And they can seek care in our civilian hospitals. But if we don't know anything about them, they'll come in and say, well, I was exposed to Agent Orange. And I say, yeah, I heard about that from my grandfather or something. You know, and so it's really about the same thing. It's about health disparities. And if I could, for the health disparities, I love what's being said. I love all of the innovation, teaching people forward to eliminate bias and things like that. But we still have a big problem with the people like me who were trained 30 years ago, because I was trained the wrong way. I was trained that a big black man in the ER doesn't need pain meds because he's a big black man. I mean, what? I was trained that black mothers don't need pain medicine when they're giving birth. And I'm like, what? And then I'm a dermatologist. And we have all these lilting, beautiful descriptions, colors, and everything like that. And I'm being told about this violacious thing. And I stopped the professor and I said, well, what about in really brown and black people? You can't see purple. How do you diagnose this disease if it's all based on a violacious color? Because all the descriptions were in white people, not in people of color. So we've got a lot of work now to eliminate and erase the issues, the renal function tests that are biased, the pulmonary function tests that we know are biased. So many things that we were taught to believe in as the truth are flawed and are false and are not the truth. So as we move forward in the future to teach these new generations, we need to stop and teach the old folks. I got a beautiful picture of my dad from 1936, an intern, graduated from Meharry. Beautiful black man standing in his whites with a medical bag next to a car that says Kansas City Health Department, sick call car, colored division. We are not that far removed from that. That was 1936. That might as well have been 1996 for all intents and purposes. I still get called to the ward sometimes by a black patient who has said, Dr. Coots, you have a racist health system. I'm like, what are you talking about? I'm a black CEO. I got a lot of black staff. We're eliminating it left and right. And she said, well, why is it when I tried to explain my health journey, they did not listen? I have a PhD and a master's in healthcare administration. I know I'm obese and I have cornrows, and all they saw was obese and cornrows and did not listen to my story. They did not see me. So we have got to get to the point where all this other stuff is great, but we got to stop and see people for who they are and recognize them so that we can actually treat them and give them the best health care possible and give them the best life possible.
Dr. Daniel, the medical community has reached consensus that obesity is a serious chronic disease. We know this disease especially affects Black African American communities. What are the top health policy opportunities to improve care for vulnerable populations?
Thanks for that question. And I want to just pick up on what you just left with, because so many times a patient with obesity goes into the provider's office and they get that reaction, which is, you have obesity, go change your diet or do something else, but it's not a medical condition. So one of the top issues with obesity is it's not commonly viewed as a chronic condition. And so therefore, many in the medical community don't treat it as a chronic condition and don't treat patients who have obesity as somebody who needs help from the medical side. I think you all know the statistics. This surprised me. Obesity is associated with about 200 comorbidities. 100 million people in the United States have obesity, and I mentioned before disproportionate, and we all know disproportionately affects Blacks and Hispanics. We talk about legislation. Right now, the Medicare program not only doesn't cover anti-obesity medications, and there's a new anti-obesity medication that's on the market, been shown in a recent study to reduce the incidence of diabetes by 60%. Significant weight loss. This is not a Lilly product, by the way, but there are more being reviewed by FDA. Despite the effectiveness of these anti-obesity medications, not only can Medicare does not cover it, it's illegal for any Medicare Part D plan to actually cover anti-obesity medications. What's covered? Bariatric surgery. So if you look at who has access to bariatric surgery, it's not the underserved population, I can assure you. So what do we need to do? There's a piece of legislation out there. It's called TROA, Treat and Reduce Obesity Act. There are two major provisions in TROA. One is to just remove the blockade from Medicare Part D plans so that plans can actually cover anti-obesity medications. That's the first thing. The second thing is improving coverage of intensive behavioral therapy. One interesting issue, the federal health employees, the federal employee benefits. So if you work for the federal government, they have announced they are going to cover anti-obesity medication. So if you work for Medicare, you have coverage and access. If you're covered by Medicare, you do not. That is a significant issue. This policy was about 20 years ago. It made sense then. 20 years ago, like fen Redux, those were the, not very effective, not very safe. Made a lot of sense to not even use those products in patients with obesity. We're not 20 years ago. Our policy is antiquated. Obesity is a chronic condition. It results in, if you factor in both healthcare costs and impact on productivity, $1.4 trillion because of obesity. And we don't provide access to anti-obesity medications that are effective. I think that's an issue.
Thank you. And I know we have a question to my left right now. So I'm going to acknowledge you. Please say your name.
Is it on?
There we go.
Hi. Okay. Hello, my name is Alita Jury Carter. I'm one of the 40 under 40 honorees. Thank you. This is an amazing panel. I feel like this is Super Soul Sunday for people that are working in health equity. So I have so many questions, but I'll narrow it down to two. The first is just understanding the historical context of where the American medical infrastructure has been developed from, right? It's come from an oppressive history. The 3/5 Compromise was a part of the original Constitution of the United States. So the first question is, do we think that there will be a day where healthcare access will be recognized as a basic human right and be able to build that into our Constitution like other countries like Germany? And then the other question was, I think often people don't recognize that food is medicine, right? If you abuse it, it becomes substance abuse. If you use it properly, you can use it to act as anti-inflammatories and do so many other different things. And even a few health insurance will actually allow providers to prescribe fresh produce and things like that to help their patients. So how do we close that care gap and get that message to the community to say food is medicine? And while there is Western medicine that we can prescribe to you, this is your first line. And then the first question is, again, do we think that it's realistic for us to think without a constitutional overhaul that healthcare access will be recognized as a basic human right?
John, do you want to start with this one?
Oh, you start with me on that one. Well, I can say unequivocally, I can't answer your question about the Constitution. No, I love history intensely. And, you know, this is the interesting history of our country and where all the goes. So I'll leave that. But I can talk about history of food of medicine. And I'm sure a number of people in this room heard of Dr. Jack Geiger. I was supposed to meet him shortly before he left this earth. I was so excited. I'm going up to New York to meet him, but he famously started writing prescriptions for food in the 60s in the Mississippi Delta. And he got a visit from a federal worker and said, I noticed you've been writing prescriptions for food. He responded back, the last time I looked, the treatment for malnourishment was food. And so it goes from there. But that is very common. You'll see it a lot of on the Medicare as well, but certainly a lot on the Medicaid side. There's a lot of engagement around that. I want to share two vignettes just to underscore that, and started with some of what Dr. Kus was talking about really seeing people. We had an issue. This is beyond just the food piece. We did a study on a population where I was running a plan of kids who were having a lot of ER visits from asthma. So wanted to go out and wanted to see what was going on. So we're going home to find out. And it's the kind of things you would tend to think. There were folks who had different issues. Some of them had issues of, hey, you just need to have help a vacuum and clean up your environment. Help you with that, fine. And then in some other issues, we found that some people smoke. They may not stop smoking. Okay, fine. Well, at least go outside. How about that? It's all going fine. But then there came this anomaly, and I dubbed it hidden paradox. So hold on, because it has two parts. And so what we noticed is that in a few of the homes in particular, they had kids there who had asthma, and they had a lot of kittens. And you knew they were allergic to cats, but you kept the cats. We didn't quite get that right away. And so what we figured out and understood by taking time and listening is that cats were there for two reasons. One, they had mice. Now, whether it worked or not, didn't matter. They thought that it did, so they had them there for that. But there was a second part, too. The second part was the neighbors had mice. So they allowed the cats to have kittens because they could sell them. And it was a second economy. Resource challenge, very vulnerable families, figuring it out. It was very smart. They had Medicaid. ER visit was covered. It's other things that I need, food and all this other stuff, wasn't. And so as you start to look at communities and what's important to them, you have to pay attention to what's going on. Where is it there? And often enough, it's not something that's necessarily health related. It affects their health, but the intervention has to be different. The care managers were really astute. They would tell us all the time, we could help this family if we had just a month to work with the family. But the issue is, what I have to do to help them is not going to be clinically related. It's going to be the things around their life. Again, this is an vulnerable community. And so it's that kind of insight and willingness to do something. And then, plans have different constraints depending on what state they're in and all those kinds of things. And getting creative about, what you do about it. And the thing that I learned from the home care was this. You need a patient that's willing and capable. And the last thing I've thrown in is imagination, because you have to get creative about how you go about what you're doing. Ergo, Jack Geiger writing prescriptions.
Can I answer the question as well? So just real quickly, she also asked about the future. Will we see a point in time when everyone has access to care, whether it's legislated or not? And I think we will, but I think it's still a ways off. And unfortunately, the National Medical Association has been saying healthcare is a right, not a privilege since 1898. Since 1898, that's a long time. So we've got a ways to go. We've come a long way, but we have a ways to go. The pandemic was the great disruptor that we've been waiting for. It wasn't Berkshire Hathaway. It wasn't CVS, Aetna. It wasn't anything like that. We need to take the opportunity that we have been disrupted to now throw all the old broken stuff away and move forward and recognize that access is the number one problem in American healthcare.
Yeah, could I add one thing to that?
Please.
Real fast. And this just happened to me. And this is just to your point at the very end. And I, with Dr. Geiger, by the way, I actually did meet him, and that whole model of him prescribing food, he actually picked it up from South Africa because he did a fellowship. It was in townships when people were still in conflict. He took that model and the community health center model and brought that to the United States. He was the first person with his partner to get a HRSA grant to start the community health center movement. So just got to give a shout out to South Africa. I used to live there. So, but to the gentleman at the end, we talk about healthcare as a human right, and to answer to the young lady's question, this happened to me about 2 months ago. I have my health insurance through the ACA, okay? And my premium shot up $200 from 1 year to the next. When I called and I asked the person on the phone, I said, well, that's crazy. I'm not her exact response to me, and I'm going to quote this, and it was horrible. She said, well, you live in a zip code 20002. Your obesity numbers in your neighborhood are X amount. And she literally said, you live around too many fat people, and that's why this is a quote. We're scattering the costs. So my healthcare premium went from $902 to over $1,100. Okay. So I agree. So what I said to the woman was, number one, don't ever say that again, because you've just stigmatized my entire neighborhood, But I think that there's a reality when people realize what it takes to make the reality of healthcare should be a basic human right. I agree with that. But when people start to monetize it and start to put it into those kinds of terms, then you get people starting to back away and sort of not get on board. And I remember when I had that conversation, I was so horrified. I actually called Blue Cross Blue Shield. I mean, I'll just say it. And I recorded the conversation. And I said, this is what your person said to me on the phone, not knowing that half of my family is obese. So I think that it's a very complicated situation. I agree healthcare should be a basic human right, but I think we are so long away from reaching that because it's so monetized. And when you start hitting people in the wallet, people start thinking about where they're going to holiday, where they're going to summer. Can I send my kids to Choate? Can they still go to Spence? And then people start making decisions that make it very difficult for us to realize that when we're healthier together, we're stronger together. But I think that we're a long way off from that.
And I want to make sure that we get to the other questions. So real quick, Dr. Bucker.
Yeah, sure.
and Dr.
So I'm going to be the contrarian tonight, which is not unusual. So, we have to learn how to deliver health care to every American. I'm not saying that it's going to happen tomorrow, but what I am saying is we have to start down that road. And anyone who's doing healthcare for 2 seconds understands that it's a science-based area. Not just science in the sense of clinical science, but science even at the financial level. We have to put demonstration projects in place so that we learn how to provide healthcare given all of our unique capabilities. Let me give you a very precise example, because I look at this data all the time. So if you look at the Medicare program in diabetes, 60% of everyone in the Medicare program being treated for diabetes, they either go to the emergency room or they have an inpatient stay. And I'm talking about, if you take the numbers from 2015 to 2020, because we haven't seen the latest data, complete flat line in terms of the number of hospitalizations and ER visits in the program. So in the program, 60% of everyone with diabetes going to the emergency room or an inpatient stay, right? 90% of the dollars spent on diabetes in the Medicare program is hospitalization and ER days, right? If you look at the bottom of the pyramid, where the majority is, we spend less than $1,000 on their care. And so the way the system works, we call it the acute care model. We just wait until they go up the chain, they have that first hospitalization, and then you can predict 35, 40% of them are going to go to the hospital the next year. And if you go to the hospital the next year, the possibility of you going to the hospital the third year increases. That's the system. And there's no learning. There's nothing in the system that says, oh my goodness, we need to learn how to do better. We need to invest to make sure that people in the Medicare program that have diabetes are not marching to the hospital every day. And if you're following what's going on, so right now in the Medicare program, it's somewhere around 65 million people. By the time we get to 2030, there'll be about 75 million Americans in the Medicare program. The incidence of diabetes is about 25%. So you do 25% times 75 million, times 60% hospitalization and ER visits, and the system collapses, right? Because you can't possibly hospitalize and put all those number of people in the emergency room. That's what we're talking about in reimagining.
And Dr. Underwood, just a minute, because I want to get to the three questions we have in the back corner. So did you want to jump in on
Yeah,
this
I was
one?
going to say what he described as a business model, right? You know, that's it. It's a business, and if we don't transform our business model, we will be out of business, right? That's it. I mean, and if we can reframe the conversation, we can get everyone on board to show that our competitive edge is no longer a competitive edge, right? And for us to survive in the future, we have to solve these problems, and all hands on deck to do it.
All right, back out to the mic. Thank you for your patience.
Thank you. This is an excellent panel, by the way. I'm really taking everything in. My name is Anne Noel. I am originally from Haiti. And about 4 years ago, I lived in Miami and I interned as a medical translator for the Haitian and Hispanic community, where I was translating in medical settings for them. And one of the major things I experienced was that the lack of cultural competence towards underserved, especially towards immigrant community. And so even my father and my grandmother, I moved here a year ago to pursue my doctoral degree. And every time they go to the hospital, I have to stop whatever I'm doing, get on the phone to translate for them. And as of today, I looked up the statistic. It says that immigrants today account for 13.7% of the US population. And I believe that language can be a barrier, but at the same time, it can also be an opportunity that we can take in order to improve health equity. And so my question is that one of the things that is important, yet we often overlook, is how we educate those healthcare providers. So my question is, how do we work towards this goal of improving healthcare communication for vulnerable population despite of their native language? And what are the policies that are in place for that? Thank you.
Thank you.
Like you.
We're going to show a hand. Dr. Weinstock?
Yeah, I'll say one thing. This is going to sound horrible. I can see you hiding. Come on. Yeah, come on. A big part of it is when someone makes an error. And I'll give you a really hardcore example. This happened about 10 years ago. There was a woman who was, I was interning. I was in grad school, doing my master's. And they didn't have a translator. And they brought a janitor into the room. And it was an OBGYN visit. And it was a male janitor. And the woman was Peruvian. So already that's whack that they would do that. Try to translate. He didn't really translate things really accurately. But then when it came time for her to get her dosage, because what she ended up having was an STI, She got the bottle, and as anyone who speaks Spanish knows, ONCE once a day for us means 1 pill, but in Spanish it means 11. So she went home and took 11 pills, and then came back almost in cardiac arrest. So that was when that facility said, we need to change the way we're doing things. So a lot of the time, sadly, it takes an error for people to realize. But then the other piece of it also is that it takes folks speaking up and saying, this is not okay, and I recognize that, people talk about the class standards all the time, and they've been talking about them for 20 years, but they change all the time, and you can't teach culture. You can't teach, that kind of stuff. But you can, and we should do a better job with at least translation. So what you're saying, I totally hear what you're saying. I've seen it 1,000 times. It's awful when it happens. But I think that what I've seen is change happens when there's a huge mistake. And then people are forced to recognize that, to your point, it's affecting their business model and their bottom line. That's probably not what you want to hear, but that is a big part of what affects change.
Thank you. Do we have another question?
Hi, I'm Siobhan Westcott. I'm Athabascan from Alaska, which means in the Declaration of Independence, I would be referred to as a merciless Indian savage. Seriously, Thomas Jefferson wrote that. So members of federally recognized tribes are the only group in America born with the right to health care. And yet our life expectancy is almost 20 years less than Asian Americans. That's not knowing your grandkids' difference. Treaties are made, broken. And this is just the native example, but we all have reasons that the federal government has not lived up to what was promised. What I'm asking you, Gary, specifically, I feel like things aren't going to change until we change Congress. Can we add a component of 40 under 40 to consider running for office?
So at the end of the day, and I live here in Washington. I love Washington. I work with members, but they're the lagging indicator, right? They respond to the American public. And so it isn't Congress that we need to change. It's a conversation with the American people that has to happen. Because, and I say this in all honesty, if you went door to door and you asked everyone the kind of healthcare system that you would like for yourself and your family, you're going to get one heck of an answer, right? Because they're going to tell you exactly the healthcare system that we all imagine. The problem is, and really the hard problem is, that when you ask them what kind of healthcare should we give your neighbor, that's when we get confounded. What the hell, neighbor? I don't want to pay for him. He's obese. He just does this. He does that. He walks backwards. He walks frontwards. I don't like the way he looks. Right. That's the problem, right? And members of Congress, and we see it every day playing out loud, only reflect that. So the deeper conversation that has to be had is to help the American people understand the purpose of health. Because at the end of the day, you know what the truth is? We cannot build a healthcare system for the 1%. That's why Steve Jobs is not here anymore. That's why Senator Kennedy is not here anymore, because we cannot build a healthcare system for those who think they're privileged. We have to build a healthcare system for everyone, because we have to generalize that cost across the population. So that is, and that's the beauty of democracy, right? Because we can have that conversation. We can teach people, but that's the work at hand. That's why it's going to be such a long journey. And trust me, we African Americans have been on one hell of a journey. We were slaves, right? We had to talk our way out of slavery. Then we had to talk our way out of segregation. Right? But that's the journey. And that's the journey that's healthy. That's what we're talking about when we talk about health equity. We're talking about a conversation that has to go on deep inside the American public at each generation. We have to teach them, and that's how we'll get there. So changing members of Congress is just going to get a look-alike at the moment because they're responding to the communities that they come.
Now, if I can jump in on the members of Congress and the communities and the 40 under 40, a lot of the folks in this room have a relationship with the Congressional Black Caucus Institute. The Institute does have a congressional training academy where members of Congress, those who are sympathetic to health equity, health disparities conversations, can nominate folks from their district. And a lot of these 40 under 40s come from CBC districts. So they can get a nomination to enter into the Congressional Black Caucus Institute's training academy, if you would. So I encourage you to look online at the CBC. And I think we have another question.
Hi, I'm Bakari. I work with NMQF at Comms. I guess I wanted to ask Gary where he saw the contradiction between, things about the diabetes, things like the diabetes chart, where the acute care model, because it seems like the acute care model is part of, like you said, the business model of the current system. And there's only a contradiction between things like the acute care model and healthcare being a universal human right if we don't change those things first. But I feel like there's not a contradiction between that and healthcare being right, because if healthcare systems are accountable to people, the public will be enough to make the changes to the things like the acute care model. And I'm curious what you and the other panelists' thoughts are on that.
So diabetes, like a lot of chronic diseases in American society, is fixable, right? So we haven't really invested it the way we should in that metabolic disease, so that we have the science, technology to manage pre-diabetes. Because understand what diabetes is. It's you're cooking your body in sugar. That's in effect what you're doing. Your body's being cooked in sugar. And even when we talk about you're pre-diabetic, you're already cooking your heart and your vascular systems in sugar. We're only talking about it when you're full-blown symptomatic going to hell, right? That's what we say that we need to intervene. We have to intervene way upstream, and we have the capacity and tools to do that. We are so close now, and I want to embarrass the folks at Dexcom and others, but they're so close to having that artificial pancreas because those continuous blood glucose monitors are now starting to drive insulin pumps. That technology is going to be there shortly. The question is, how do we provide that? So roughly 38% of everyone with diabetes in the United States is minority. An African American with diabetes and ischemic heart disease has a 90% hospitalization rate. Who has a 90% hospitalization, right? But that's the number. They're all going to the hospital. And I think what's profoundly important about that statement is, I challenge you to name a national program in which we say we are going to manage diabetes in our community. It's like having a garden. It's getting overrun with weeds. You walk by it every day. You say, we got a real weed problem here that we need to get fixed, but I'll wait until tomorrow. I think about it next week. That is the problem. That's what the reimagining is about. We need to take on a disease like diabetes and say, we need to make a strategic investment in it because it'll bring down the cost. At the end of the day, it will bring down the cost because we want to control diabetes. It's not just manage it. We want to control it. That's the investment. It's like when we had the flat screen TV when they came out in the 1990s, the $25,000, you can have a flat screen TV. Now you can buy one for $200. You can do the same thing with diabetes. I mean, think about it. And so it's really about will. Yes, at this point, it's just flat out will. Do you want to do that or don't you? And right now, the will is not there. It's not, I'm talking about the public will. The public.
So,
Can
so
I-
Dr. Martin Luther King said,
No,
okay,
no, no.
okay. So Dr. Martin Luther King said it's easy to integrate a lunch. Everything else is going to be very, very. Why? Because a lunch counter costs nothing, right? Therefore, you tolerate sitting next to a black person while you're eating. But other than that, everything else is going to take public will. So again, how do you change the public will, right? And that has to be a focus. That means that you begin to weave the story in such a way that every person who's receiving that story realizes that a problem with hypertension is not Willie's problem, it's your problem, right? It's my problem. So I'll give you an example. AMA has a great project, great program. I'm looking at hypertension, and we adopted it in Buffalo. And we're working with a hospital system. I'm not going to share their name, so we got the project. But I was able to bring Highmark, Blue Cross Shield, Independent Health. These insurance companies are competitors. They can't get in the same room without fighting, but they came together around this project, right? We're funding it, resources working together. Simple project, right? Home health blood pressure monitorings. The doctors get paid to receive the information, and they get paid to address it, right? Can't get better than that. This is great. So I'm project, and I'm the medical director of the Buffalo Center for Health Equity, the research guy. So here you go. I'm on the phone with him, and I would think this. I said, well, the alarm goes off when your blood pressure meet a certain thing. I'm assuming that it's 120/80, right? Maybe 130/80. And I'm talking to the doctor. He said, no. We have patients, we got different parameters. I was like, different parameters? What are you talking about? He said, because see, this guy over here, if his blood pressure is we can get it down to 170/100, this would be great. And I'm like, that's stroke level. So, and I'm having this conversation, and of course, my head is exploding, right? So I said, oh, we have to figure out how good blood pressure control is the same for every single individual, right? And we have an expectation that if you sit in this seat that says MD, that's your priority. That's your goal. That's number one priority, is to make sure that that person gets the best healthcare possible, right? And I'm not going to set a standard that is so far for this individual because I think that that's the best we can do. Right? So, yes, that's a point. Now, are we there? No. But we have to think strategically to get there. So when we think about reimagining, we don't do it from a failure perspective. We do it from a perspective that is that what is best? And what do we need to put in place to receive best? Like an athletic team, right? Get what I'm saying? If you're a coach at any level, let's use football. I play football. You're a bad high school football coach, you don't get a job the next year, right? Coaches in the NFL who go to the playoffs yearly get fired because they can't win a Super Bowl, right? But it's okay that we have 50% of hypertensive not being treated, right? What percent of diabetic? Oh, a buddy of mine, one of my frat brothers, went to college together. He calls me up to ask a question about some urinary stuff. And I started asking about his hemoglobin A1C. And he said, I was told that it's good. I said, what is it? He said, somewhere between 6 and 7. So I said, you know what I call someone who has a hemoglobin with between 6 and 7? He says, what, Sans? I said, diabetic. I said, dude, you're a diabetic. All right? It's simple. You're diabetic. He said, well, I'm diabetic, so you're diabetic. What should I do about it? Get it treated. Call him up, get it treated. So then I heard the story. He hadn't seen his doctor in 6 years and all this kind of craziness, which I smacked him over the phone and cursed him out a little bit. But that's what it's going to take. At multiple levels that we decide enough is enough and too much stinks. And the cool thing about this is what we need. A strategic plan that includes all of us, right, across the board saying, let's make it happen, right? And failure is not acceptable. I'm speaking as Willie, but I'm going to speak as the AMA too. We're on board with that. So let's make it happen.
Thank you. John, you want to take us home?
Sure. And picking up on the energy Dr. Underwood has had throughout the about business, all of healthcare, when you look at American health, talking about $4.5 trillion. If there were a sovereign nation, that'd be the 5th largest economy. It was bad, quite bad. But here's the other anomaly that goes along with it, just back to social determinants. We know right now that only 20% of your health outcomes actually come from everything. But that's not what's funded. That's not where the business. That's an opportunity for the future. That's that willing, capable, and imagination again. You're starting to have snippets of it now around, what plans are doing just in terms of what they're doing supporting issues of like housing, food insecurity. But it goes beyond that. It's back to that, kitten paradox issue that we talked about, even with diabetes. As you begin to look at that and how you go about that and what you're going to do about it, it has to become something that's just not looked at through the clinical vein. You can't get there from here. That's just my personal opinion. But when working with complex populations, if you don't look at the other part, yeah, you can go get the prescription. We were writing the prescriptions for the asthma. That wasn't the issue. And so it's got to be that kind of creativity that, comes to bear, and certainly the alignment across stakeholders that are there. But there's an element sitting out there right now. This is kind of like an iceberg theory of there's all this other stuff out there that we have to look at if we value health and what that means. And so in some ways, it's a defining of health. What is health? Is it a purpose of living or is it a resource for living? And then what are you going to do about how you fund it? And so as you look across, it's very vast. You can do a lot on community levels, and we see that a lot. But that kind of voice, that kind of energy is going to be very important. This is a little bit of a change. I have something here I want to share with everyone. It's a good news thing because we're talking about things that reimagining and things that are wrong. But not everything is necessarily wrong. And someone shared an email with me. And this is from a Black father who was very anxious about going to the hospital. And he wrote this, and he sends it to the healthcare system that took care of him. And here's what he's saying. So we're changing gears just a little bit. I arrived in the emergency room on March 8th in excruciating pain. Talked about it. I waited 6 days at my home before I came to the hospital for treatment. From the moment I arrived, I was given priority and treated with compassion, and most of all, humanity. I was confused, delirious, and my wife was in tears as she feared for my safety. The ER physician evaluated me, listened to my concerns, and made sure I was admitted to the hospital. She took the time to see that I was in deep distress. I spent the next 3 days and 2 nights in the hospital. While in the hospital, the entire staff with whom I interacted not only were well-trained and professional, but they also had compassion and a wonderful, uplifting spirit I needed to recover and come home to my family. And they go on and identify, I am an African-American husband and father, and I have a new respect for the American healthcare system and how it works for communities of color. It is good to know that there's a hospital in my community, his community, that my family can trust during a life-changing event. He shared this with the hospital system. The CEO shared it with the staff. The notes were everything from tears and a lot of other things. But the whole point is, if you care, if you're intentional, you can make a difference today. That's not tomorrow.
And I think that's the right note right there for us to close on. And as we do, I want to have 2 rounds of thanks. And I'll steal the first one from my good friend, Don Calloway. There are people who arrived long before us to set up and who will stay long after us to clean up and who are looking after us throughout this evening. So I want to first give a round of applause to our support staff, caterers. And what about this panel right here? I think this is right? Great discussion. We went into short overtime. I think we could have gone into double overtime, but we'll spare that tonight, but we'll continue the conversation on the floor and tomorrow. So thank you all for attending and have a wonderful evening.
Very powerful. Very, very.